Good morning, everybody. Thank you so much for joining for the grand rounds this morning. The speaker for today is Dr. Amir Arain. Dr. Arain is an epileptologist from University of Utah. Dr. Arain did his graduate education from Dow Medical College in Pakistan, followed by a master's in public health at Vanderbilt University. He then did his internship at McLaren Regional Medical Center in Flint, Michigan, and then a neurology residency at Vanderbilt University Medical Center, followed by a clinical fellowship in epilepsy neurophysiology at Vanderbilt. Dr. Arain has been a faculty at Vanderbilt for a long time, and he served in various roles there. And a few years ago, he moved to University of Utah, where he now serves as the chief of epilepsy division in the Department of Neurology there as a professor. Dr. Arain has extensive academic experience. He's a member of several organizations. He has published more than 50 manuscripts. He has trained more than 100 fellows, including myself, and he has mentored several fellows. And it is an honor to have you here, Dr. Arain, today. So we're very happy to have you here and excited for your talk. So Dr. Arain is going to talk to us about the complex interplay between sleep and epilepsy.
Thank you, Dr. Sagi. Thank you for inviting me, and thank you all for taking time to come and listen to my talk. I'll talk about sleep and epilepsy. So epilepsy, as you know, is a common neurological condition. About 1 in every 26 people have epilepsy. And about 50% to 2/3 of patients with epilepsy complain of sleep disorder issues. So the objective of this talk is to understand the relationship between sleep and epilepsy, differentiating seizures versus parasomnias, and sleep-related epileptic encephalopathies, and then neuromodulation and sleep apnea. So Hippocrates in 400 BC or so noticed that many patients in sleep groaning and crying out, some in state of suffocation, some jumping up and fleeing outdoors, deprived of their reason until they awaken and afterwards become well and rational as before. Although they may be pale and weak, and this will happen not once, but frequently. And then Aristotle noticed that for many patients, seizures start in their sleep, but not when awake. And Gowers in 1880 observed that about 21% of patients have seizures primarily in sleep. And Lancet in 1994 published this article of autosomal dominant frontal lobe epilepsy that was previously considered as a sleep disorder. And then ILE now classifies that as a sleep-related hypermotor epilepsy. So sleep and epilepsy have a reciprocal relationship. 20% have sleep-related seizures only, and 40% have seizures only in waking, and the rest have seizures in daytime and night.
I apologize for interrupting, but it's hard to hear you in person. Could you speak up a little bit or get
Sure.
closer to your mic?
Yeah, let me get closer to my mic. Can you hear me better?
Yeah, that's a little bit better.
Sorry about that. So sleep and epilepsy have a reciprocal relationship. Sharp waves are activated in sleep, especially in the stage 2 and slow wave sleep. So we divided epilepsies into 3 different types, which are sleep according to the sleep-wake cycle. Sleep-related seizures are epilepsies where they only happen in sleep. Sleep accentuated are the ones which happen in both in awake and asleep, but interictal epileptiform discharges, and sometimes particular type of seizures can happen in sleep as well. And then awakening related seizures that are primarily seen in juvenile myoclonic epilepsy. And there is another classification of epilepsy, which is like epilepsy with grand mal seizures upon awakening. And they typically happen shortly after waking. Differentiating parasomnias and seizures can be challenging. So to avoid misdiagnosis, careful history is very important. Another topic that can help you differentiate between the two is the stereotypical nature. All epileptic seizures are stereotypical, meaning they're similar each time because they're coming from the same circuitry, while parasomnias can change. And then obviously video EEG is the gold standard of diagnosing seizures and parasomnias. So here is a vicious cycle between sleep and epilepsy. Anticonvulsants and sleep disorders can affect sleep and cause sleep fragmentation. That affects the quality of sleep, and that promotes seizures. And then seizures can cause excessive daytime sleepiness, adverse effects on learning and behavior, and can further lower seizure threshold. So it's a vicious cycle between the two. Sleep-wake disorders in adults with epilepsy are 2 to 3 times common than the general population. And questionnaires based study in 175 patients back in 2020, they looked at sleep disorders in patients with epilepsy, and they found that patients who have epilepsy compared to control have higher chance of having insomnia, sleep bruxism, and RLS, restless leg syndrome. Obstructive sleep apnea was 2.5 times common in adults with epilepsy than in age-matched healthy controls, threefold likely to occur in men compared to women. And then late onset epilepsy, having status epilepticus and or worsening of epilepsy in middle-aged adults, always consider untreated obstructive sleep apnea. So they should be evaluated for sleep apnea. In this study, they noticed that onset of sleep apnea coincided with the first episode of status epilepticus or a clear increase in seizure frequency in middle-aged individuals. So also they noticed that this sleep apnea is more likely to appear in adults with epilepsy if they're older, sleepier, heavier, and had their first seizures when they're older. So sleep begets epilepsy, and the coding of overnight sleep improves the yield of intrarectal epileptiform discharges. So we know this for decades that if you include slow sleep in your outpatient EEG, that improves the yield of finding epileptiform discharges. Sleep deprivation activates epileptiform discharges independent of sleep duration or depth. Spikes and sharps are seen particularly during the deeper stages of non-REM sleep, stage 2 and 3. Intrarectal epileptiform discharges are seen less frequently, and they have a narrowest field during the REM sleep. Maybe less frequent in phasic than tonic REM. What we mean by that during REM, the epileptiform discharges are more restricted or localized, is that if you have multiple foci during non-REM or waking, during REM, this field narrows down to the main focus of the seizures. So it's always good to look at, if you have multiple foci, you have to look at REM sleep, and looking at the epileptiform discharges can tell you the main focus. Sharp activity is increased in non-REM sleep. We talked about stage 2, decreased in slow wave sleep, and severely decreased in REM. In clinicals like slow wave sleep, CSWS. Sleep affects seizures, varies by the epilepsy syndromes. Nocturnal seizures are less disruptive and carry a better prognosis. This was by one study in 1998. Seizures are rare during REM, just like intrarectal discharges are rare during REM. Seizures are less likely. Relative hypersynchrony present during non-REM sleep that promotes seizure and epileptiform discharges. Temporal focal seizures more likely to generalize in sleep compared to waking, usually in N2 or N3. So here you can see that focal seizures are common in N1 and 2 and then decrease. And seizures generalize more frequently in N3. And these are the sleep-related epilepsies, sleep-related hypermotor epilepsy, Penny-Topless syndrome, or benign epilepsy of childhood with centrotemporal spikes. This was an interesting study looking at patients, children with drug refractory epilepsy. They compared that to well-controlled epilepsy in healthy children. They underwent video EEG monitoring with added channels of EMG and EOG on the electric eye leads to help stage sleep. And in drug-refractory epilepsy, when no activity bereft of interictal discharges, they looked at the underlying voltage in the background. And then multifocal interictal epileptiform discharges, benzodiazepine use, longer duration of epilepsy were independently associated with lower sleep efficiency and lower REM time. Multifocal interictal epileptiform discharges, sleep cerebral palsy were independently associated with lower spindle count. So not only they had lower REM time, lower sleep efficiency, also they had lower spindle count. Benzodiazepine use, drug resistance, seizures during sleep, intellectual disability, they were all associated with lower slow wave activity that declined overnight. Significantly more caregivers in the drug refractory epilepsy group than well-controlled group reported that sleep problems in the child affected overall family dynamics. So the interaction between disturbed sleep, intellectual disability, interictal epileptiform discharges, sleep, they all were significantly seen in patients with drug refractory epilepsy. REM can be a sleep biomarker to track progression of disease. Loss of REM to indicate worsening of disease or reappearance of REM can be a marker of disease modification or disease improvement. Slow wave activity decline could be seen as a marker to assess the efficacy of the treatment. So correcting abnormal sleep patterns in drug-resistant epilepsy improves cognitive outcome of these children too. This is Dr. William Landau, who described Landau-Kleffner syndrome, which is an acquired aphasia. It has a gender predisposition, more in boys, typically presents from age 3 to 8. They have marked epileptiform discharges in EEG in sleep. Seizures are milder than the ESES. Excuse me. Charts typically increase during sleep. Language deficit results from the persistent epileptiform discharge. So these are normal children until they start having Landau-Kleffner syndrome. So they have a lot of epileptiform discharges, and there's a language decline in these patients. And there's hypometabolism seen on SPECT, and language improves after resolution of spike waves. So if you treat the condition with seizure medications and the spike wave index improves, then their language outcome improves as well. So here's an EEG, which can be primarily localized to the dominant temporal lobe, but you can also see wide field generalized discharges as well. Here you can see EEG recorded during non-REM sleep. There is an increase in epileptiform activity. If you do EEG without sleep in these patients, they may have a normal EEG, but once they go into stage 2 sleep, there's this increased activation of epileptiform discharges. So this condition is interesting. This is an acquired aphasia. There's no consensus in treatment. Longer duration of epileptic activity worsens the prognosis. Aim of treatment is to restore language skills and control seizures. Epilepsy in Landau-Kleffner has a good prognosis. Most patients become seizure-free. Medications that are typically used are clobazam, levetiracetam, and valproic acid. Continuous spike wave discharges in sleep, CSWS, is an age-related epileptic encephalopathy. It's on the same spectrum as Landau-Kleffner, with more cognitive dysfunction in these patients. They present at 2 months to 12 years. Seizures are unilateral, clonic, or tonic-clonic, typically occurring out of sleep. Can be focal or generalized seizures during sleep, atypical absences when they are awake. So tonic seizures do not occur in these patients. EEG shows continuous spike wave pattern during like slow wave sleep. It can last months to years. Prognosis is guarded because of the appearance of neuropsychological disorder. Let me show you the EEG on these patients. This is while awake. So this child has only just one generalized discharge, otherwise a normal background. But when 10 minutes later in the sleep, You can see that there's a continuous spike wave discharges, which is like electrical status epilepticus during slow wave sleep. This is another example of wide field generalized discharges. This is a 9-year-old sleep EEG with frequent, almost continuous status epilepticus in sleep. So CSWS is associated with new cognitive deficits and behavioral disturbances. These children are normal until they start having the manifestation of the condition. They have regression in global cognitive functioning, IQ decrease, severe behavioral and cognitive abnormalities are seen. Some of the features that we see with these children is dyscalculia, dyslexia, hemi-neglect, short-term memory impairment, aggressiveness, deficits in relatedness or inhibition. And they can have encoparesis or enuresis and bizarre behavior. On the EEG, previously, the diagnostic criteria was to have spike wave index of at least 85% during non-REM sleep. That has been changed. Now there is no set criteria as such. If you see a global decline in the child, and also you can see generalized discharges activated, a wide field discharge is activated during a non-REM sleep, that is sufficient enough to classify that as CSWS. You see 1.5 to 2 hertz generalized spike in wave discharges as soon as the patient falls asleep. It has been associated with some genetic disorders. 50% have malformation or cortical lesions like polymicrogyria, migration disorders, schizencephaly, porencephaly, hypoxic ischemic encephalopathy can present this with this as well. The mechanism of cognitive deficit is not known. Cognitive functioning may improve when spike waves are reduced. As far as the treatment is concerned, people have tried different things like steroids and IVIG, ketogenic diet, multiple subfield transactions have been done. Vagus nerve stimulation have been used. With long-term outcome is variable depending on the etiology. Duration also of CSWS and the treatment response. Peniotopoulos syndrome is a benign age-related focal occipital epilepsy. This is 8 times less common than benign Rolandic epilepsy, which was previously called benign Rolandic, now called benign epilepsy of childhood with centrotemporal spikes. Onset is between age 1 to 14 years. 70% have seizures primarily in sleep. 17% have in wakefulness also. They also have autonomic features like nausea, retching, vomiting, pallor, flushing, incontinence of urine or bowel. Here you can see the epileptiform discharges primarily in right occipital area. Here you have both sides, left and right, and then you have wide field involvement. Mostly the epileptiform discharges are limited to occipital area or posterior head region, but you can see wide field progression as well. Multifocal high voltage spikes often shifting from one region to another can be seen. Occipital spikes are the most common, followed by temporal spikes and brief 2 to 3 seconds generalized spike in wave activity when awake. Prognosis is excellent. Recurrent seizures are often treated with the carbamazepine. Rectal diazepam for home administration or nasal diazepam or midazolam can be used for prolonged seizures. Remission usually occurs within 1 to 2 years of onset, and most patients recover well. Some may still have some issues. On the same spectrum is benign epilepsy with centrotemporal spikes, previously called benign Rolandic epilepsy. Onset is a little later, 3 to 13 years of age, with remission before the age of 16. Typically present with hemiclonic facial twitching. If you remember, the centrotemporal spikes correspond to the motor homunculus, mostly in the face area. So these children wake up in sleep with face drawing and drooling, come to their parents. They are not able to tell them, but they are having constant contraction of their facial muscles on one side. Focal aware seizures, yeah, typically they are aware, but they cannot speak during the seizure. Spreading to homolateral arm or leg with secondary generalization rarely can occur. Here you can see the discharges in a bipolar montage. They are bilateral here. Decreasing the sensitivity, you can see that phase reversal is at T8 and C4, so centrotemporal area, but it can have a wider field. On an average, you can see that they're wide field, but decreasing sensitivity, you can see the negativity primarily is at P3, P4, and C3, C4. And then there is the positivity up front, with the sharp waves are flipped. So this is a positive dipole, and negativity is in the centrotemporal area. So this is one example where you see centrotemporal spikes with a horizontal dipole with bifrontal positivity. Here you put it in average in the linked year montage, and you can see that the positivity is up front primarily, and the negativity is in P3, C4 area. Seizure frequency is usually low and approximately 70% occur during sleep. Treatment only necessary when it is disturbing, especially in the school performance. I was trained by Dr. Fenichel, and he was reluctant in treating them unless the child is sleepy during the day or having effect on their academic performance. Then he would typically start levetiracetam or carbamazepine or oxcarbazepine. Juvenile myoclonic epilepsy, autosomal dominant with strong penetrance, occurs at 8 to 26 years of age. It's a female predominant condition. Myoclonic jerks without loss of consciousness happens. So it's one example where you have generalized bilateral activity, but without alteration of awareness. They typically happen after waking or after late afternoon. And so most of these patients report of having seizures while they're getting ready for school or in the shower. So we have a JME protocol in EEG where they come in sleep deprived and then let them sleep, and we wake them up and report within the 20 minutes to improve or increase the yield of finding abnormality. Typically affects more upper extremity, but can involve lower extremities as well. I'm going to show you some examples. So you saw a sudden jerk. Here's another example. He has multiple myoclonic jerks. Repeated myoclonic jerks, you can see. These. You can see that more involves the more upper extremity, but can involve the lower extremity as well. But predominantly in the lower extremity, we don't see that with myoclonic seizures. Here is the EEG associated with myoclonic jerks, generalized spike and wave discharges. The frequency is about 4 to 6 hertz. This is faster than the childhood absence, which is like 3 hertz. So they have faster frequencies. And in sleep, they can become more polyspiky. Here's an example of another burst of generalized 4 to 5 hertz spike and wave discharge. So it can have a normal EEG if you don't capture drowsiness or sleep. It doesn't exclude JME. So best thing is to record after they wake up. Long-term video EEG monitoring in sleep, you can record that typically they have seizures or myoclonic seizures during waking, shortly after waking. This epilepsy is very sensitive to sleep deprivation, so we ask them to change their lifestyle, have a good night's sleep. That improves the seizure outcome. Lifelong treatment is recommended. People have done the longitudinal study. In this retrospective study, They were followed for 44 years. Range was from 20 to 69 years, and revealed that about 25% of these patients could come off the medication. It has a strong recurrence risk, so we typically leave them on medications. Medication-wise, valproic acid, zonisamide. Valproic acid is still considered to be the drug of choice, but not in young women with childbearing potential because of intellectual teratogenicity. Lamotrigine can be used, but may aggravate some myoclonic jerks. Levetiracetam is often tried, topiramate. Other medication that can be used is zonisamide, perampanel, clobazam, carbamazepine, oxcarbazepine, gabapentin, phenytoin, tiagabine, and vigabatrin have been associated with aggravation of absence seizures and myoclonic seizures in juvenile myoclonic epilepsy. So try to avoid those. Nocturnal frontal lobe epilepsy is an autosomal dominant condition. Onset is in childhood. Almost all seizures occur during non-REM. Seizures occasionally occur during waking. Distinguishing nocturnal frontal lobe epilepsy from non-epileptic parasomnias is sometimes difficult. Here's an example of an EEG with the nocturnal frontal lobe epilepsy. You can see onset of seizure predominantly in the left frontal area. All cases have a good response to carbamazepine, but not to some of the other anti-seizure medications. They often have a high frequency of seizures, more than 20 per month and several per night. And on the other hand, parasomnias have less frequent, less than 14 per month, or maybe 1 or 2 per night. These frontal lobe seizures are less than 2 minutes, like other seizures, while parasomnias can last several minutes. Again, the point I wanted to make is that for frontal lobe epilepsy, or epilepsy in general, the seizures are always stereotypical. While parasomnias, non-epileptic spells, they are not stereotypical. And in frontal lobe seizures, typically happen in non-REM sleep, while parasomnias happen in slow wave sleep. And recall favors nocturnal frontal lobe epilepsy, while you don't see that with parasomnias. So here, disorders of arousal in non-REM sleep tend to disappear throughout life. The REM parasomnias, often in a neurodegenerative condition like REM behavior disorder, usually late onset, last third of the night, while the non-REM parasomnias typically happen in the first half of the night. On the other hand, sleep-related hypermotor epilepsy can be at any age, anytime during the night, several per night. They are brief duration. They are stereotyped motor patterns. And let me show you an example of that. And now you can see adversive eyes and head turning to the left side. And now it's over. So it's a short seizure coming out of sleep and stereotypical. All his seizures were like this. On the other hand, this patient, is in REM sleep right now. Let me show you another example of sleep-related hypermotor epilepsy. So this one gives you a pattern where the arms are coming up and the legs are abducted This is typically seen with supplementary motor area seizures. And most of these are focal aware seizures. If you ask them to remember something, they would remember it. And post-ictal phase is minimal or maybe very short. Here is an example of a parasomnia. This is REM behavior disorder. He was in REM, and then suddenly there is burst of muscle artifact. So this was REM behavior disorder. This is the frontal lobe seizure. You can see the legs abducting and the arms coming up. Again, the supplementary motor posturing. In these patients, their fingers are released, so they can move the hands, but they cannot bring their arms down during that. So stereotypical nature of this helps you to separate from parasomnias. It's over now. Here's another example. This is a frontal tonic seizure. The sustained posture, you can notice. So now. This is another example of parasomnia. REM behavior disorder. This is a patient, telefactor EEG. Half of the screen is EEG and the rest is video. We're trying to do ictal SPECT in this patient. So she was sleeping and started thrashing. She had a focus in the right frontal operculum. Became seizure-free with resection. Yeah. In epileptic seizures, sometimes you see patients turning prone in bed. But look at her behavior is pretty hyper, restlessness. So she's in focal impaired awareness seizures. She's not able to respond. So she's able to answer some questions. Let me show you another example. This is an example of sleep myoclonus. She was in stage 1 sleep and had muscle artifact with discharge. This is a frontal lobe seizure. And you can see the posturing with supplementary motor focus, eyes rolled back, legs are parted. So supplementary motor area seizure. Sleep deprivation for diagnosis of epilepsy is often used in EMU when patients are suspected to have epilepsy. We typically do it in the hospital. For our outpatient EEG, we typically ask them not to sleep deprive all night. They just ask them to go to sleep 2 hours later than their normal sleep time and wake up 2 hours early. So this is good enough sleep deprivation for outpatient. And it's very helpful for JME, as I said, JME protocol. But for in the hospital, we do alternate night sleep deprivation to provoke seizures. Temporal lobe patients report increased wakefulness after sleep onset compared with frontal lobes patients. Nocturnal seizures decrease in REM, an increase in stage 1 and decrease in sleep efficiency, typically. That's what they complain of. Following focal status epilepticus, a study by Basel reported that severe inhibition of REM can be seen for several days. So here you can see that in REM, the seizures are less common, early seizures than the control, compared to stage 1, where you see more predominance of seizures. Phase shifts of melatonin secretion have been demonstrated in both adults and children with epilepsy. Overall decreases in melatonin levels have been described. The effect of melatonin on seizures is equivocal at the moment, because some studies say that it helps. Sometimes some they say that they don't help. But worsening of seizures have not been seen with melatonin. So anti-seizure medications affect on sleep. There are some medicines that can worsen sleep. There are some that can improve sleep. And all we know about slow wave sleep is improved by gabapentin and pregabalin. Among the seizure medicines, felbamate and lamotrigine both are very alerting. So it can affect sleep onset. So they have often difficulty falling asleep. REM behavior can be affected by benzos and phenytoin. RLS can be worsened with lamotrigine also. In case of lamotrigine, we tell patients not to take it close to their bedtime. If they are being affected and having insomnia, we ask them to take it no later than 6 p.m. But in the morning, they can have it with their breakfast. That helps, but sometimes we do often need to give them medication if insomnia is significant with lamotrigine. Lastly, I'm going to talk about neuromodulation and sleep, vagus nerve stimulation. You're familiar with that. This modality is for treatment of epilepsy. In studies with lower VNS intensity, less than 1.5 milliampere, improved daytime sleepiness, improved quality of life, increased sleep onset REM, and increased N3 sleep seen in children. Higher VNS intensities like more than 1.5, increased arousals, increased wake time after sleep onset, reduced percentages of REM sleep, increased mean sleep latency, can worsen sleep apnea. And so it's always recommended that before putting someone on via VNS, you should get like sleep study if there's a concern about sleep poor quality. So getting sleep study, PSG, before VNS implant is very important, and also repeat it after VNS have been implanted. Beth Mallow reported that VNS may exacerbate sleep apnea. From Vanderbilt, there were 4 patients. PSG was done before and after 3 months of treatment with VNS. 2 patients underwent follow-up PSG to assess the effect of changing stimulus parameters. All patients showed sleep-related decreases in airflow during VNS activation. In one patient, obstructive sleep apnea before VNS treatment, AHI was 4, and that increased to 11.3 after VNS implant. So lowering stimulus frequency in these patients improved hypopneas and apneas. So not necessarily changing sleep stimulus intensity, pulse width, or on time, just decreasing the stimulus frequency was strong enough to ameliorate the VNS related effect. Here's another study by Marzek. They had like 16 adults underwent PSG at baseline and 3 months after the VNS therapy initiation. 5 of the patients had AHI of more than 5, and respiratory events were more frequent during periods with VNS activation than without VNS activation. and this was statistically significant. Esophageal pressure also monitored in these patients. One of the patients showed crescendo in esophageal pressure during VNS activation, supporting an obstructive pattern. And CPAP trial of patient 1 showed all respiratory events were associated with VNS stimulation at low CPAP value. When the CPAP levels were increased, that resolved the respiratory events. Treatment with VNS affects respiration during sleep and should be used with care in patients with pre-existing sleep apnea. So here's an example from Beth Mellows, where you have this is the channel for VNS, and you can see when it turns on, you can see that there is a drop in nasal cannula airflow. Here's another one where you can see that it comes when the VNS turns on, you start seeing hypopnea and apnea. This was at a setting of 1.5 milliampere, 30 hertz, and they decreased the frequency to 20 hertz, and that really ameliorated the effect on apnea. You can see there's no apnea. They didn't decrease the output current. Current is 1.5, just decreasing the frequency to 20 hertz improved the sleep apnea. So effect of vagus nerve stimulation on the quality of sleep and sleep apnea in patients with drug-resistant epilepsy. Systematic review. Systematic review and a meta-analysis. Overall, the effect of VNS on quality of sleep remains unclear as studies were very heterogeneous. I showed you a couple where it does affect sleep apnea. The effect on sleep apnea is consistently shown with increase in sleep apnea severity, and this is after VNS implantation. About RNS, NeuroPace, which is a device that is almost like an artificial intelligence. So it detects seizure focus, and once the seizure activity comes on, it shocks the brain. That has been studied for sleep apnea worsening. Here, the focus is directly connected to the device through a strip or a depth electrode. In a study of 134 patients, intellectual epileptiform discharges have a nocturnal peak. Seizures were also from nocturnal, new cortical brain regions have a nocturnal peak. Seizures arising from the limbic or temporal area peak during the day with a complex pattern. In this study by Roof, noticed that sleep disruption is not observed with brain responsive neurostimulation. They had only 6 patients with RNS, and they had PSG. RNS of new cortical and mesial temporal targets do not disrupt sleep. Arousals typically happen just before rather than after stimulation, they noticed. So RNS has not been associated with worsening of sleep apnea. Let's talk about the deep brain stimulation. You're familiar with that with Parkinson's, but it's also approved for treatment of epilepsy. FDA has approved it for anterior thalamic bilateral stimulation, but we have used for stimulation of central median nucleus if you have a wider field seizure onset or in generalized epilepsy. There is a trial which is for idiopathic generalized epilepsy with deep brain stimulation and shows some benefit. So in this study of 9 patients with anterior thalamic nucleus, DBS, electroclinical arousals was triggered in 14 to 67% of all deep brain stimuli. 6 patients reported neuropsychiatric symptoms too. Nocturnal DBS voltage was reduced and then PSG was repeated in this study, and they noticed that electroclinical arousals occurred less often, 1.4 to 6 times more frequently than during stimulation. Number of arousals positively correlated with the level of DBS voltage. No patients experienced seizure deterioration. 4 patients reported remission of neuropsychiatric symptoms. So having low DBS voltage improves the effect on sleep in these patients. Lastly, sleep disorder and SUDEP. SUDEP is a sudden unexpected death in epilepsy. It's a severe complication seen in about 1% of patients with refractory epilepsy in a tertiary care epilepsy center. SUDEP accounts for about 15% of epilepsy-related deaths. In outpatient studies, the incidence is about 1 per 1,000, but for inpatient studies that come to epilepsy monitoring unit and more refractory epilepsy, the incidence is about 1%. So adults with epilepsy have 2.5-fold higher mortality rate and 27 times higher rate of SUDEP than general population. Nocturnal seizures increase the risk for SUDEP 2.5 times. Nocturnal seizures associated with, because the nocturnal seizures are associated with severe and longer oxygen desaturations. And also they are more associated with post-ictal generalized EEG suppression, what is called PGES. It's a biomarker for SUDEP in patients. People have studied PGES, and patients who ended up having SUDEP, they had PGES, like post-generalized EEG suppression in their EMU monitoring. So that is one of the biomarker. The longer the PGES, like EEG suppression after generalized seizure, more than 30 seconds, it increases the risk of SUDEP. So finally, conclusion is that sleep and epilepsy have a bidirectional relationship. Parasomnias can mimic seizures, and anti-seizure medications can affect sleep. We talked about some medications worsening sleep, like felbamate and lamotrigine. Treating sleep apnea improves the seizure control. So it's always recommended that if you're putting someone with vagus nerve stimulation, get a PCSG if there is an issue about sleep quality. So, and also repeat it after VNS implant. So I'll stop here and answer any questions.
Dr. Arain, thank you for that really insightful talk.
Thank you.
I think on every slide that you spoke, it was just incredible amount of very, very pertinent information. So thank you so much. My question has to do, Dr. Arain, with the real, problem we have with, SUDEP. And what happens in patients who are well controlled, certainly in the refractory patients, but even in patients who are well controlled, having really infrequent seizures or what have you, every now and then, we see this happen. What can we really do in trying to decrease the incidence of this problem outside of saying, well, we need to better control seizures, etc.? What can we do? What are these wearable devices doing? What are other things doing? What is your sense of where we are going with managing SUDEP better?
So certainly patients who have refractory epilepsy and are not controlled, especially with the generalized tonic-clonic seizure, that is a risk factor. So controlling their generalized tonic-clonic seizure is very important. That certainly decreases the risk of having SUDEP. And there was a study by Sperling who looked at after epilepsy surgery, if their generalized tonic-clonic seizures were controlled, their risk of SUDEP was back to the baseline as general population. So controlling the generalized tonic-clonic seizures is most important with medications or with surgical treatment. That's one. There are these devices that are available that are very helpful, that can set off an alarm. Having a bed partner, even that improves the risk for SUDEP, because when they're turning in bed, that somehow stimulates them. So patients who have no bed partner, sleeping alone, they have a higher risk of having SUDEP. Another thing is that the pillows, that's very important, that pillows should be stiff and hard rather than soft, because in some of these seizures, we notice that they turn prone and they can get suffocated during the seizure. So these are the things that can help. So devices are very helpful. There's an Embrace 2 watch now that can detect generalized tonic-clonic seizures and can set off an alarm. So these things are important, but treating generalized tonic-clonic seizures is very important. Compliance is very important. Most of these patients who end up with SUDEP, their anti-seizure medication levels are minimal. So they have not been taking it. This is a condition of young people, very productive. So if we can prevent that with seizure medication or with epilepsy surgery, so having a delay of epilepsy surgery for 20 years is not acceptable in this age. So certainly we need to treat those seizures, especially the generalized tonic-clonic seizures.
Thank you.
Yeah. Having baby monitors are also very helpful because now they have like videos associated with it. So having it in the patient's room if there's concern is also helpful.
Thank you so much, Arain. That was a wonderful talk. Thank you so much for doing it.
You're welcome. Thank you for inviting me.
Thank you. Thank you very much.
Thanks. Thank you.
Thank you from in person.
Thank you. Thank you, Dominic. Thank you for arranging this.